think Joan's frozen again, Jess.
Yeah, I think so. Yeah, I think I'll just do the intro for us. So, good afternoon, everyone, and thanks for joining us. My name is Jess Barry, and I'm the administration assistant for the Education Division and a research assistant for NARI's Clinical Gerontology Division. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that's the Wurundjeri Woiwurrung people. And I would also like to acknowledge the traditional owners of the lands and waters across Australia. I pay my respects to elders past and present and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generations. Firstly, just a little housekeeping regarding the Zoom. At the conclusion of the talk, we will have some time for a Q&A. If you have questions, you can submit them throughout the seminar in the chat function, which is opened using the chat tab at the bottom of your screen. Today's seminar will be recorded and uploaded onto our website within a few days. Please keep in mind, if you turn on your video to ask a question, your image will be included in the recording. Today we'll be hearing from Dr. Sharyn Milnes. Sharyn trained as a registered nurse at the Royal Melbourne Hospital in 1985. She has completed postgraduate studies across the disciplines of nursing, education, and ethics. Her research includes the translation of ethics and communication to good end-of-life care and medical education. Sharyn currently works at Barwon Health, teaching communication, ethics, and interprofessional collaboration. And today she'll be presenting Putting Patient Values into Shared Decision-Making. Welcome, Sharyn, and over to you.
Thank you. Just let me start my little timer to make sure I don't rant too much. Hello, everybody. Thank you for having me and for the opportunity to speak to you today about my research. I thank you, Jess, for doing the acknowledgement of country. I'd like to acknowledge that I'm on Wadawurrung land today. And as I do my very quick acknowledgement of being on Wadawurrung country, the unceded land of the Wadawurrung people, you're looking at a painting here by a young, very proud Gunditjmara Kirrai Wurrung woman, and some of you may be on Gunditjmara country. This is by Taryn Love, and it's called Kalpiran Kalkurtnan, and that's Kirrai Wurrung language. This translates to the silent dead. It symbolises the Aboriginal massacres in southwest Victoria back at the time of colonialisation. And those little dots are actually people. You can see that they're stick figures. And these represent the countless indistinguishable figures that convey our dark and violent history and the breaking or trying to break a culture. Art, of course, has many meanings, and as well as a very important First Nations message, the silent dead reminds me of the duty we all carry to those who die in our care. So I would also like to acknowledge that I'm on, as I said, Wadawurrung country, and pay my sincere respects to their elders past, present, and emerging, and acknowledge their enduring connections to country, to waterways, to cultural sites, and thank them for their amazing custodianship of this beautiful country that I'm on. So, I'm going to start with a story. Like all interesting talks, like the TED Talks, when I thought about this talk, this is actually something that happened not long ago. And I can tell you my PhD is one of the longest in history, so it started a while ago. But this happened to me earlier this year. This is actually my father in this photo. I think Dad was 89 there. And he was doing some filming for us for education, for communication skills. And the doctor in there, Vish, was one of our ICU registrars. I took Dad. So Dad, as I said, is now 92, and Dad's now got a vascular dementia. So physically he's still pretty fit, but cognitively Dad is declining quite quickly. Of course, being the father of someone like me, we had advanced care plans done some time ago. But with this sudden change in Dad's cognition, I took him to update his advanced care plan a couple of months ago. And there were some fantastic questions that were asked at the beginning about what Dad valued, what a good life looks like for him, what he would find intolerable. Now, I've had this conversation with my parents a number of times, each time they go into hospital. And Dad talked about exactly what it would look like for him, where he would say, enough is enough. Then what happened was the advanced care planning facilitator then said, so Brian, if your heart was to stop or you were to stop breathing, would you like us to come in and try and start it again? And I just thought, this is a question that I teach doctors not to ask. It's exactly the red flag for me. And of course, my father, when asked, if your heart was to stop, would you like us to start it again, said, well, yes, why wouldn't you? So what this told me, and we'll come back to this, what did this tell me? It told me that the information we gather from people is very important, but so too are the questions we ask and how we ask them. So over the next 20 minutes or so, I'm going to be describing to you what we've achieved over the last 10 years with a program called iValidate. And also where we're trying to go in the future with our program. How we've tried to improve care for people at high risk of dying by teaching healthcare professionals to ask what matters to individuals, to listen to what they say, and then to incorporate that information into advice, recommendations, a deliberation and a discussion about the options of care that are right for each individual person. It sounds simple, doesn't it? So let's just make sure that we're talking about the same thing here. The picture that each of us holds in our mind about what is patient-centered care, what is shared decision-making. And I'm going to use an example of a patient that came into our hospital. So a few years ago, a 83-year-old woman came into our hospital with worsening of her underlying disease, a precarious situation if you're on home oxygen. She was admitted to the ward, got a bit worse, more breathless, her work of breathing got a lot harder, and on her first day was referred to the intensive care unit for more support. The ward doctors and nurses were worried that they couldn't reduce her work of breathing, that she was suffering. The intensive care were worried that they would be asked to ventilate an older person with chronic end-stage lung disease who was actively dying. Fearsome that they would be asked to provide burdensome and unhelpful interventions for end-of-life care. The patient and family were worried because they just wanted her safe and comfortable. There was a lot of emotion beginning to surface. So what would help a situation like this is a document that addresses all of these worries, that guides the care of the patient to what to do in the exact situation that we found ourselves, where her work of breathing was going up. She was looking like she needed some sort of intervention to ease her anxiety and difficulty in respiration. She did have what we call a goals of care form. Some of you might remember them as a do not resuscitate form. They're now called a goals of care form, and they're quite different to the ones that we had certainly 10, 15 years ago. Now, this was what her goals of care form indicated. It just said, does not want CPR, however, would like NIV, non-invasive ventilation. And down the bottom, HDU was ticked. So we see countless versions of something like this every year, all the time. And I've audited over 4,000 of these forms for my PhD. So is this one okay, or is something missing? If we were to audit patient-centred care and shared decision-making, would this get a tick because the form is in her notes? And would we say, is this a marker of patient-centred care? So when certain areas of the hospital do audits of goals of care forms, this would get a tick. This would say, yes, this lady has a goals of care form. Yes, she was involved in the conversation, simply because something is written there. But it's not okay. It's not shared decision-making. There's no patient voice here. And it shouldn't be considered patient-centred care. So let me sort out shared decision-making. So shared decision-making in the literature, and I won't go into this too much, but it's been talked about since the 70s. What shared decision-making looks like is it really is when the rubber hits the road for patient-centred care. It's absolutely the clinician and the patient coming together to transfer information, deliberate, and make decisions together. We clinicians are the experts in the evidence and our experience for what happens. The patients are the experts in their life, how they live their life, how they want to live their life, their values, goals, and preferences. Now, this says doctor, and I'm sorry, but you can transpose that word doctor with clinician. I'm just going to give you a second to have a look at that. So Kathy Charles and her group back in the 90s did a lot of work. They started looking at breast cancer, but they moved on and did a lot more work across healthcare, looking at decision-making and how it actually happens. Before this, we had a lot of theoretical writings in the literature about how decisions happen, how we should be communicating with people. Some of you may know that Sentinel article by Emmanuel and Emmanuel. So what Charles and her group found is that when decisions in healthcare happen, there are three phases. There's a phase of information transfer. Then there's deliberation on that information. And then a decision is made. And then what they found, they actually start with 4 different types of decisions, but as their population got larger, they found that no, they could really identify 3 types of decision-making that was occurring in healthcare, depending on what was happening in each of these phases. So you can see there in the paternalistic decision-making, information transfer is one way, clinician to patient and or family. The deliberation is done the physician, the clinician alone, and the decision is the clinician's. So when I'm a registered nurse working on a surgical ward and I get a post-op patient back, the decision about doing routine post-anaesthetic obs on my post-op patient is a paternalistic one. I will certainly be telling the patient what I'm doing. So the information transfer will be myself as the clinician to the patient. But the decision about those obs, what happens with those obs when I do them, and the deliberation and decision is mine. That's paternalistic, and that's okay. We do that at times. I want to go to informed next, because a lot of people think they're doing shared decision-making when they're doing informed. In informed decision-making, the information is all clinician to patient or family and or loved ones, one way, but the deliberation and the decision is left with the patient and or significant others. So that's thing that this facilitator, the ACP facilitator, did with my dad. So she got information from Dad. There was a bit of backward and forward, but then that question of, if your heart were to stop, would you want us to run in and start it again? Meant the deliberation and the decision all sat with my father. That's informed. Shared decision-making is two-way all the way. So shared decision-making is when we have information transfer backward and forward, which was happening at the start of the ACP conversation with Dad. But deliberation and decision should also be two-way. So what I did is I said, can we just stop here? Dad, if your heart was to stop or you were to stop breathing at your age, with your past history of heart problems, the only way you're going to end up, if we try and restart your heart, is in the situation that you've described as unacceptable. So can we talk about that, please? And then there was backward and forward about, again, what would that look like? What does that mean? Can I communicate with my family? So the deliberation was done together. And the decision was made that we would not rush in and try and resuscitate him. So then it became a shared decision. Some people prefer pictures. This is another way to look at those three different types of decision making. So some people speak about shared decision making most simply as providing a bridge for patient autonomy, where our voice as people are clearly heard and our right to self-determination is respected, but supported in a relational way, not just that menu option of what do you want us to do, like the informed. It's a very relational definition or way to treat autonomy. So shared decision-making brings together clinicians and patients. We find out from patients and their significant others what matters to them. What are their goals? What are their values? And what are the preferences involved when they're in hospital, the sorts of things that matter to them? We give them advice based on this. We talk about choices in care where we might be able to actually achieve those goals or not. We discuss the choices, the risks, the benefits, the likelihood of success. What is success for a person? The best and worst outcomes. We deliberate and we make plans together. And finally, we document this, and we've got to document it in a succinct way that is meaningful for people that come to the patient in the middle of the night when they are having these acute deteriorations. I just want to quickly talk here about the difference between advanced care planning and goals of care documentation, because a lot of people get confused about this, and an advanced care plan certainly can provide the impetus for a goals of care conversation. So an advanced care plan is a broad idea about acceptable and unacceptable outcomes for patients. Now in Victoria, we have legislation that recognises our values-based cares, advanced care directives, and our instructional directives. They are there for the time they're made forward and should be updated as necessary, like I did with my father. A goals of care documentation is something that usually occurs for each acute admission, and it is a revisiting of the conversation for this patient at this time in this admission. Clear options of care are discussed, and it's usually about a potential acute deterioration. So there are certain patients we know have a higher likelihood of deterioration, and I'll talk about who those patients are. So in that, you can see down the bottom there in step 4, the treatment decision, we have a clear pathway for what is right for this person if they have an acute deterioration. So that's a goals of care form. What I've put up here, it's actually an old advanced care plan, and those who have seen the new ones that come under our new Act will know what they look like, but it's a similar sort of idea of what's documented here on this one. This is the old statement of choices. So you can see here, I enjoy my independence. I enjoy working on my car, and I value my freedom and being able to make my own choices. So these are very values-based, which we do have a values advanced care directive in Victoria, very useful for decision-making. And you can see there, they go on to talk about if I have a stroke and I'm unable to feed myself, so on and so forth. So again, some really lovely directions there for the staff. Now, what we ask staff to do is look to see if a patient's got an advanced care directive. If they have, take it off, take it to the bedside and say, can we talk about what you've said in this advanced care directive? And if you are to have a situation where we're worried we're going to need to do a lot of things to you, what that means for what you've said in this directive. So it's the launch pad, if you like, for the goals of care conversation. Oh, sorry. So back to our lady on the ward. Sorry, I'm going between Dad and the lady. So we had this goals of care form that was with her on the ward, and she was beginning to deteriorate. When the intensive care clinicians went and saw her, they talked to her. They found out about her life, what mattered to her, her goals, and we come up with this more nuanced document. So Lady X is a lovely woman who lives at home with her husband. Despite her frailty and limited exercise tolerance, she values being at home and especially spending time with her 2 dogs. She spends the majority of her day reading, enjoying the company of her dogs and small house chores like cooking, and putting out the washing. Despite being limited by her shortness of breath, she still finds joy and happiness in the life she is currently living and would like to retain her current level of independence. And then we talk a little bit about how do we align that patient information with options of care. So this lady has end-stage COPD on 24-hour home oxygen. She was admitted to ICU with infective exacerbation, currently on minimal oxygen requirements, vasopressors, IV antibiotics. She understands the severity of her COPD and aware that CPR and intubation, so being put on a breathing machine, would unlikely get her back to her current function. She has previously trialled non-invasive ventilation with significant improvement, but she is unable to lie flat for a big IV to be inserted. Therefore, vasopressors are not feasible. So there are certain drugs we cannot give. And then the plan aligns with that. So that is shared decision-making. We've found out her values. We've found out her goal to go back to how she was. And her preference is to go back home and live the way she was. But her preference was also to have non-invasive, but she understands no to intubation and ventilation and intubation. Now, the skeptics will say, that's nice, but you ended up with the same decision, HDU care. And if we reduce the measure of our care to a tick in the box like this, we have a problem in healthcare. So what we will see is we will see a lot more prolonged invasive death with a lot of tension and distress on one side, that form we saw initially, where there was a lot of emotion, or a simpler plan of care with a patient and a family who feel listened to, who we can step carefully through important decisions together, and a reduction in the moral burden on our staff. So we can see benefits in this, but we want to improve even more. So some questions about our shared decision-making program, and the last three are what I answered in my PhD. So first of all, does it matter? We saw that we had that same tick box for HDU with this lady. So does it matter if we do this shared decision-making well with people? Pardon me, sorry, I'm just getting over flu. Well, yes, society seems to think it does matter. Those of you who may have read Govonde's book, Being Mortal, talks all about this, listening to people, talking to them about what they want life to look like for them. There are a lot more research coming out looking at exactly this.
Thank you.
And interestingly, those of you who have been through accreditation will know that particularly the partnering with consumers and the comprehensive care standards are full of shared decision-making, and you have to show that you're doing it, but doing it in a meaningful way, not just this ticker box, like that first form we saw. So we can't say we have done shared decision-making when we see that first form, because we don't know. So as I said, these three questions are what formed the basis of my PhD. So the first thing we wanted to look at was, so do we actually have a problem? Do we have a lot of patients for whom we can identify as being at a significant risk of deterioration? And are we talking to them? So our first studies, these are the studies that we looked at. I'm sorry, I should have put that before. These are the studies that made up my PhD, trying to answer those questions. So you can see in 2015, the first one we did was a prevalence study. So when we had a look at the prevalence of patients with what we now call life-limiting illness, we found that around a third of our overall patient population did indeed have a life-limiting illness. And the life-limiting illnesses fell into three trajectories. There was the organ failure trajectory, which was organ failure towards the end of life. Towards the end of the trajectory. So generally it was organ failure that required help with ADLs. So we looked at renal failure. There were also some identifiers such as EGFR for renal failure. We looked at FEV1 for COPD, left ventricular ejection fraction for CCF, so on and so forth. So there are a number of criteria in the organ failures. So that's one trajectory. The other trajectory was cancer, and that was metastatic or not amenable to treatment. And the other one was actually called the functional decline trajectory, and it included frailty, and we used the clinical frailty score. And I'll talk a little bit more about that because we've just done a big database study of frailty in ICU, as well as dementia towards the end, and residing in residential aged care also falls into the functional decline trajectory. Now, these trajectories are well validated. They're taken from the SPICT tool, which is a palliative care tool, and the gold standard framework, which some of you may have heard of. That was a tool that was originally used in primary care in the UK, but has since been validated in acute care settings as well as rehab and secondary care settings. So at baseline, as I said, we found a third of our patients in our acute care setting at Barwon Health had the presence of one or more life-limiting illness. The prevalence for patients referred to intensive care from our organisation, again, we found around a third of those had presence of a life-limiting illness. The outcomes for these patients, where they had a high 1-year mortality, their 12-month mortality was 50%, their 3-year mortality got up around 80%. So we felt that we had identified the right group of patients who definitely should be having that shared decision-making for goals of care early on. These patients spend longer in the emergency department, significantly longer in the emergency department than patients without life-limiting illness. They're more likely to be admitted than patients without life-limiting illness. And we also know that around of this group of patients, of that third with life-limiting illness, a third of them will require the medical emergency team, the MET call, within the first 1.5 days of admission. So these are a group of patients that it's important for us to have a nice early conversation with. So these patients are complex, they've got a lot of comorbidities, and the care they receive have a big impact on them. What we also found in the early days with this group of patients was less than 10% had any indication in the whole history. So I looked at the whole history of their admissions of being involved in a conversation. Now, I know a number of you are thinking, but they could have been, it's just not written in the history. Yep, you're right. But when that poor little resident goes to the MET call in the middle of the night and nothing is written, everybody will default to high intervention ICU care. It's just what happens. And it might not be A, what they want, and B, what is right for them. as you heard, with a conversation with my father and this lady. So we built a program, and I apologise, I haven't updated the numbers. Gosh, 2021, I'm sorry. But this was from our article where we described the program, iValidate. So we built this program where patients with life-limiting illness are identified early. We ensure they have a capacity assessment and the right surrogate decision maker is identified. Then there is a conversation where values, goals, and preferences are identified and discussed. Medical advice is given based on that information. Options are discussed if they are to have an acute deterioration. And then there is consensus. We make sure everybody knows about this, that the relatives are aware of the conversation that's occurred if they weren't there, that the other teams involved are aware of the conversation. And very importantly, so as a part of the process, we developed this new goals of care form. It is documented. And that this form should follow them and be checked with the patient. Our next thing is to get a signature of the patient or the relatives on the bottom, so as we're sure that they're being involved. As you can see, so in 2021, we'd educated around 1,000 people. We've now educated close to 3,000 people in this process, but importantly, in the communication skills for step 3, 4, and 5. So the other thing that we've done is we've listened carefully to patients and the relatives in these conversations. We asked a group of lay people, what are the values that are important to them and that they would like prioritised if they were to come into hospital very sick. Then what we did, after we had enough of our goals of care forms that were being completed well, I did a content analysis on those forms and looked at what were the values, goals, and preferences being identified on those forms, because the only evidence, we didn't have local evidence of values that were important to people. We only had North American, the Northern Hemisphere, nearly all North American data about the values from Canada and the US. And there was a lot in there about religiosity and finances. And we just had a feeling that they might not be as important in the local context. And certainly, as you can see from the themes and the sub-themes, the sorts of things that came up were around independence and dignity, around the relationships and the ability to communicate and doing the things that made life meaningful to people. And people also spoke a lot about balancing quality and quantity of life. Now, the interesting thing in these forms, and as I said, I looked at around, for this study, I think I looked at around 2,500 forms. The only forms that had anything about prioritising longevity over other values were conversations had with the surrogate decision makers, none with patients. So no patient said, living as long as possible is more important to me than being able to communicate, being independent, having dignity and self-care, so on and so forth. And interestingly, and this came across, and this will be interesting for this group here, physical comfort was less important to the older groups of people than the younger groups. So when we sorted it by age brackets, physical comfort becomes less important with the older people. I thought that was interesting, not surprising. And I think they're all so used to living with a level of physical discomfort. Here's the same table, but with some of the quotes, just out of interest. I just wanted to show you, if we come down to this longevity one, so you see that it's stated in the third person because these came from surrogate decision makers. Values prolonging his life no matter the complications. For full intensive care therapy if it means he will live longer. Wants us to do everything we can for him to live. So they were all comments made by surrogates. We heard a lot, and I put this in as a goal. A lot of individuals spoke about not wanting to be a burden to their family. In the communication education, I teach the clinicians to explore that further. What does burden look like? It's something that needs to really come down. And what we find for burden is it comes down to these issues of independence and cognitive function. So we actually built a process to help support the education. So as I said, the first thing we did was we made a new form where we are required, particularly with this group with life-limiting illness, to write in the patient's voice. We want to hear about what the patient values. What are they not willing to give up for more time? What are the trade-offs? What's their understanding of their disease? And I talked to you about those steps before, and this is the process that we developed for the iValidate, the whole iValidate process. We know from work done on the knowledge to action kind of process that education only accounts for about 15 to 20% of change in behaviour. What else is involved is certainly culture, the culture of a place, you know, what is, and we know at Barwon Health now, the culture for shared decision-making is very well improved. And there is a culture now for patient inclusion in discussions and more documentation. But the other thing that really matters is process. Do you have the right processes behind this to support it moving forward? So we've developed scripts for the junior doctors to help them with these conversations that go with the goals of care forms. And we've changed where advanced care directives are kept on our system, so it's very easy to get them, print them out and take them to the bedside. We made sure that these goals of care forms sat at the bedside for every patient. So if they had a clinical deterioration and the poor little on-call, the covering doctor or the MET team comes in, the form is there, not in some folder at the nurse's station. So there are processes like that that need to be considered as well. I better move along, I'm ranting. So has this changed outcomes? Well, we hope so. We've seen a marked improvement in shared decision-making. I'll also show you our clinical outcomes, our patient and surrogate experience. We're still to have a look at that. The healthcare worker experience, I've done qualitative work with nurses and doctors, and are the systems improved? So overall, it has improved doctors' behaviour. So we know the one thing that will significantly identify whether or not a patient experiences shared decision-making is if they've been through the iValidate training. So yes, it seems to change doctors' behaviour. And you can see there that, again, the very significant about if they were seen by an iValidate trained doctor. Does it change patient and surrogate decisions? This is nuanced, but not necessarily what you would expect. So what has happened was, you can see there, iValidate trained doctors are more likely to put HCU and ward-based care than non-iValidate trained doctors. We've still got a little way to go with referral to palliative care. It may change patient outcomes, but mortality isn't the right outcome to look at. That's not what we want to look at. We want to look at what that end-of-life care looks like, and is it concordant with what the patient wants. So there is a lot coming out in the literature now about goal concordance, and that's what we want to have a look at. Will it improve hospital outcomes? Overall, we're increasingly understanding the effect of this training and the hospital outcomes. You can see there the days in hospital seemed to be decreasing with the different interventions. This is our Gen Med paper where we looked at a number of patients in our Gen Med population over a number of years. And it seems like the MET incidence significantly reduced and the readmissions significantly reduced as well. Now, I'm sorry, this is a very complicated slide. I won't spend too much time on this, just to say that we have looked at a number of different steps. So introducing the form, educating junior doctors, doing interprofessional education, so bringing the nurses and relevant allied health in. And then the next thing we did was we went up and gave a nudge. So we go up to the wards, the iValidate team go up to the wards, do spot audits of what are the patients with life-limiting illness in the ward, what's their goals of care documentation like. If they haven't got it, we go to the junior doctor and we say, would you like us to coach you with this conversation? Would you like a script? Do you want a hand? What's stopping you from having the conversation? This was a study we did where we asked people after intensive care. I think we asked 12 and 18 months after a critical illness what their experience was. And it won't surprise you to know it wasn't about whether or not they got the right drugs or the right intubation or anything. It was all about the relationships with people. The other interesting thing to note is the people from the country had worse recovery than people from in Geelong. So it seems if people are transferred across services, there's something missing there. And I think that's something we need to look at in the future. Our next steps. This is something that we've drawn up where we'd really like to have a look at the pre and post intervention study to evaluate the efficacy of implementing an organisational-wide shared decision-making intervention, looking at goal concordance as the primary outcome. So we haven't done this, but we've designed it. We're just hoping to get money to do it. Again, this is our timeline. You can 23 and beyond. We have done some of these. We've looked at aged care. which will interest you. I'm just writing that up now. We have looked at the number 13 there. You can see we've just had that published, where we looked at the core data set of Australian New Zealand Intensive Care Research Group. So that was 500,000 patients or something. And interestingly, frailty is one of the key indicators for outcome, as it is in high-risk surgery. So we're also currently looking at patients who are identified as high risk for surgery. So we've got a big program and a lot more to do. And thank you for your time in listening to me.
Thank you so much, Sharyn. We now have a bit of time for Q&A. So if you have any questions, please put them in the chat box using the chat function, or alternatively, if you'd like to ask your question in person, you can turn on your camera and microphone and we can call on you in turn. So I think we have some comments in the chat.
Everyone, they're lovely.
Yeah, they're so nice. Yes, but if anyone's got questions, feel free to put them in that chat, or you can raise your hand. Yeah, I thought that was such a great talk, and I loved how you put your dad in as an example as well. I thought that was, yeah, really great. So thanks for sharing that with us, Sharyn. And I hope you get funding for the next part as well. Very important work.
We are actually looking at, so one of the important things for this group as well is we're looking at, yes, we're looking at residential aged care, but also keeping older people at home. And
Yeah.
that was such a strong value, so that was that sense of place and independence. Staying home, yes, I'm prepared to accept some help, but I want to be home and do as much as I can. How important is that?
Yeah, that came out so strongly, especially in your the comments that you shared, the qualitative research.
Yeah.
Yeah. Yeah, so if there are no further questions, I will stop the recording, but could everybody first please thank Sharyn with your clap reactions?
Thank you.
Yeah, so next month the seminar in aging will be presented by Dr. Donna Giacotti, and she will be presenting on audiology and its relationship to dementia. Please join us then online Tuesday, the 20th of August. And once again, thank you for attending. And Sharyn, if you can stay online so I can chat to you after as well.